Good afternoon. My name is Mischelle Ferrell, and I'm the administrator of Cumberland Family Care in Sparta, Tennessee. And in this session today, I'd like to talk to you about changing the landscape of rural health clinics in Texas and in America. So let's start. I'm using the word landscape as a description for what I see rural health as today. And it is a canvas across the United States that definitely is ready for change. So let's move on. The session objectives today. I want to provide a general background about rural health clinics. I'm sure probably most of you are very familiar with rural health clinics. View the RHC landscape on a United States map, distinguish the two types of rural health clinics, highlight the Rural Health Clinic Modernization Act of 2019, and that is where we can make change. Describe the impact of COVID-19 from a personal perspective with regard to our rural health clinic. And finally, to discuss rural health stimulus and COVID-19 testing funds and what we're doing to use that money to the best of our needs and the needs of our rural community. So let's start quickly just with the Rural Health Clinic Service Act of 1977. It was law. Allowed for the provision of Medicare and Medicaid programs to pay for core medical services provided by rural health clinics. Jimmy Carter enacted this law, and the payment method was called an AIR, or an all-inclusive rate, which we've all been very familiar with over the years because it really hasn't changed in its definition. Unfortunately, the landscape of rural health clinic regulations and the payment methodology has definitely not changed much, unbelievably, over the last 40 years. The goal of the Rural Health Clinic Service Act was simple. It was meant to provide the rural and what they considered underserved communities with primary care services. There was an inadequate supply of physicians in those areas, and through this act, they could offer employment opportunities to mid-levels, nurse practitioners, physicians, assistants, and allow them to receive reimbursement from Medicare and Medicaid. So that's how we started. This is a look at our landscape from coast to coast, border to border. Today, there are roughly 4,500 rural health clinics in America, in the United States. The next screen is Hello, Texas. So there are 299 rural health clinics in the state of Texas, and they're marked just like the United States map with a green dot. So if you take a look, the cream areas are your urban areas. So you can clearly see where Dallas, Fort Worth, Houston, San Antonio, Austin, the Corpus Christi, Galveston area. And I'm not sure what the little tiny area is over in West Texas, but I'm sure all of you know. And this map identifies, in addition, critical access hospitals and FQHCs as well. But when you look at all the green dots, you see where all of your certified rural health clinics are. And when you get out into West Texas, they're far in between each other. I'm sure there's a lot of miles in between those counties. And so I'm sure that the need for rural health clinics and the prevalence of the ones that are there are very important to you as the state of Texas. There are two types of rural health clinics. The independent rural health clinic is considered freestanding. It's typically owned by physicians, And it's usually also owned by a hospital clinic whose parent is greater than 50 beds. The key that you need to remember if you are learning about, for the first time, the different types of rural health clinics is that an independent rural health clinic has a reimbursement rate that's capped. It's calculated based on criteria that is entered into an annual rural health clinic Medicare cost report, and that report is mandatory. If the report is not completed and turned in a timely basis according to CMS's regulations, then Medicare funding is stopped. I have 2020 data. The max capped rate per encounter is $86.31. And independent rural health clinics comprise around 43% of all of the rural health clinics nationwide. Provider-based is quite a bit different. They're owned by hospitals 50 beds or less. Their reimbursement rate is not based on a cap amount or a capped rate, but rather they are looked at or viewed more like a department of a hospital. So cost allocations can include lots of other departments into the rural health clinic. And they also are only a part of the hospital cost report. I don't have 2020 data on the average uncapped rate per encounter, but the 2019 data shows an average uncapped encounter rate of $216.56. And if you just scroll across and compare the two, you can see there is a significant difference in the rates of reimbursement per encounter. Provider-based rural health clinics also comprise about 57% of rural health clinics nationwide. So why change the landscape? Well, there's some disturbing trends. Since 2012, just a few facts: 388 rural health clinics have closed. 64% were independent. 312 independent rural health clinics were converted to provider-based designations. The total estimated economic impact exceeded $284 million. And equally as important, 3,600 jobs were lost. That's a pretty staggering number. And with that, it's important to me that in order for rural health clinics to continue in the future, the landscape has to be changed, and it's changed primarily through regulation. So, changing the rural health landscape, future legislation. The Rural Health Clinic Modernization Act of 2019 was also the RHC Modernization Act of 2018 and so forth, but it has now been introduced before the 116th Congress on May 16th of 2019, HR 2788. And here's the short. It's an extensive bill, and one that I hope that all of you who have an investment in rural health clinics and their future have a working knowledge of understanding what the components are. But just the short of it is that, first and foremost, it expands telehealth. It makes rural health clinics have the ability to be a distant site, and that's really important. We experienced just a taste of this through the COVID-19 pandemic, to be able to bill for telehealth services as the distant site, not the site of origin. The bill also has marked increases in the cap rate for independent RHCs. So if it were to start in 2020, which we're almost into the fourth quarter of, the cap rate proposed in the bill would have started at $105 and gone up from there through 2021 and 2022. $22 to $115, which is significantly financial improvement over $86.31 as a cap rate per encounter. The bill also addresses mid-level authorities. It permits for mid-levels to write their own orders for hospice care and home health care for their patients and things like that. It eliminates antiquated lab tests, and I really do mean antiquated lab tests. There are some lab tests that are still required to be in a waived lab of a rural health clinic that have been not significant or in the coordination of a patient's care for a long time. And last, one of the important components of the bill is that it redefines the term rural and shortage area designations. So it is an interesting bill, and certainly a giant step forward in modernizing and changing the regulations for rural health clinics to exist in the future. So when rural health clinics meet COVID-19, I can give you a personal perspective on certainly what happened with our rural health clinic and some of the negative daily, weekly problems we faced in the beginning. But to be fair, also then some of the positive responses that certainly we've experienced through this horrific pandemic. So obviously to everyone in healthcare, we had shortages. We still have shortages. Personal protective equipment is a valuable commodity. We couldn't get tests in the beginning. We couldn't get the supplies for tests in the beginning, and we ran out of products such as disinfectant spray, sanitizing liquid, just small, normally insignificant things that you use every day that became critical to providing care and in a safe environment. Test results. Well, for us, when we received a few tests to administer to patients early on in March and April, the turnaround time was pretty much after the fact. So we would get the test and the patient was either recovered, or on a ventilator somewhere. Lots of the tests that we administered were inaccurate. Bad information. This is something that isn't a secret to anybody. There was public panic. There was most definitely politics over health and safety on all the social media as well as the television. And there was non-compliance for the things that we probably could have, would have, should have done to minimize the severity of the outbreak. Our patient volume bottomed out. And our early telehealth experiences, while we were elated that we had the ability to conduct telehealth visits because patients were not coming in at all to the clinic, it was extremely confusing to us, to the patient. The platforms that we used were difficult. Many of them didn't work. And probably another great frustration in telehealth was that the protocols and the reimbursement and the protocols associated with them changed like every week for a few weeks. And our billing director was literally running herself ragged, trying to keep up with the changes in the telehealth protocol. And we were just trying to get the telehealth airplane up off of the ground, off of the tarmac. Staff. If we had one positive case at the rural health clinic, the RHC would close because it's small. So for us, in that setting, there was no work at home option. Um, it was just too difficult to try to do that, and inconsistent. Protocols, emergency disaster protocols. Well, we learned a lot about that because they changed every week. And it changed based on how our community was responding um, to the pandemic, the actual infection penetrating into our communities and into our rural areas. It was very difficult in terms of not only just emergency disaster protocol, as in the roles and responsibilities that everyone has, but how to anticipate what's going to happen from patients in our community. A good example is a patient running through the door wanting medication that they think is going to prevent them from contracting COVID-19, and being in such a panic state that it was literally a scary experience for them and for us to try to let them know that it wasn't an option, and it certainly wasn't something that they needed to come in kind of under threat about. So the landscape changed quickly, and we were going financially south as well, with no money coming in, and staff that is working and needs to work because jobs are few in rural areas, in our rural areas. It was worrisome. So come May and June and the end of April, things changed. Financial relief was probably the most important. The distribution to all rural health clinics they received between $100,000 and $150,000 in early May from the $10 billion of the Provider Relief Fund. It was probably one of the most incredible letters that I read from the NARHC executive director, giving some explanation, further detail about what this money was for, and from the Provider Relief Fund when we saw it in our bank account. We also made sure that we filled out and completed the application for the Payment Protection Program SBA loan, and made sure that we could meet the forgiveness protocols, which later were relaxed. And that was a big help. Test accuracy improved. The financial relief that was distributed to all RHCs that had to do with COVID-related expenses, that was important too, because that gave us the ability to focus just on those expenses. The telehealth protocols relaxed and platforms improved. We learned to mill around for products and things that we needed that we could not get from our discount supplier or our volume supplier, and we learned how to be creatures of going out and finding the basic needs and getting them. We kept the doors open. We kept the lines of communication open. We got our patients back into the office through services that kept them safe, and we got better living and working in our new normal. So that's how we met COVID-19 at the Rural Health Clinic in Tennessee. So I want to just share with you a little bit about how we're using our funds, because at first we really didn't know, there wasn't a lot of information on how to use the funds. Aside from the SBA, the PPP SBA loan, the stimulus funds had a much more broad definition except for the COVID-19 test-related funds. And within that capsule, it was still very broad. So the stimulus that we received in early May, we've used for human resources. We're keeping the staff employed. We're paying them while they are at home if they're sick or if they are quarantined, which has happened more than expected, that they would have an exposure and need to be quarantined for a certain period of time. We've helped to cover employee expenses for the care that they've needed. We've also made provisions for covering expenses for their child care. So those are the tracks that we're on. It doesn't take a long time to spend that amount of money when you're talking about human resources, but our HR staff, our staff is why we're here, and our patients. We can't serve them if we don't have the people to do it. COVID-19 test-related funds was a little bit more complex. So, because if you can't get tests, then you have to get a little more creative with how you're going to spend the health-related funds or the test-related funds. So what we did was we started thinking about services. So we built a carport and we opened a new service called curbside services. This way we could bring healthy patients back to the clinic for follow-up visits, Medicare wellness visits, physicals, those kinds of things, and provide curbside service and quarantined exam rooms, safe from and isolated from the other exam rooms, so that patients with any level of not feeling normal could be seen promptly and quickly, and in the comfort and safety of their own vehicles or a room set aside just for them. We installed the quarantine rooms, as I mentioned to you. We also installed lots of plexiglass. We became close friends with plexiglass because our lobby was a very open area. We finally were able to purchase rapid tests, and we purchased several hundred so that we could routinely screen our staff. And at first, that seemed a little awkward to screen your staff, but it has proven to be a pivotal decision in keeping our rural health clinic open. So using those tests for our staff as a screen and their immediate family if needed, and down the road, while our funds still last, if the rapid tests are available, they seem to have an acceptable level of accuracy to them, then we will look at testing for the patients. But right now, our turnaround time with outsourced labs is about 48 hours. So that's much better than 6 days. And we have covered the primary care expense for our uninsured patients. We do have lots of uninsured patients in and around our rural area that the rural health clinic serves. So we've tried to do exactly what was intended with these funds while keeping our doors open, our people employed, and everybody safe. And it has certainly been a trial and taken strategy to accomplish that, but we've tried to do our best. Lessons learned, just a few. As I was putting together this presentation, I started thinking about how off of normal the world has become, and everybody down to just, your personal life with your kids and your family animals, how uprooted and strange these days are. So just a few of the many lessons that we've learned here is that vulnerability is always present. And I think that we used to think, or at least I did sometimes, that we're Teflon and things just bounce off. And in this situation, it certainly taught me otherwise. Emergency disaster recovery planning is not just an exercise, but critical to survival in a crisis. And my staff, who has received their annual in-service with HIPAA and OSHA and emergency disaster recovery, have certainly, over the last couple of months, expressed their newfound attention to these types of plans. Appreciating the endurance and dedication of healthcare professionals who do provide continuous care, compassion, and they protect while carrying a great risk to themselves. And I have seen this in physician colleagues of the physician that I have worked with for almost 20 years, who have fought the great fight and become sick themselves, and but caring for patients way out in the country was their number one priority. And that the front lines of this fight are also in places with cows and barns and mountains and water as their view. It's not of city streets and parking garages and other high-rise buildings right next to the healthcare facility. Our front lines are in rural America, and there are a lot of them. And COVID-19 doesn't care where it's at. It crosses all lines. Never underestimate the enemy, and to be thankful always, because it's not just your life that can change on a dime. I learned that the world changes on a dime. So those are some of the lessons. To close, going back to the landscape of rural health clinics and why it has stayed the same over 40 years, why it's so important for it to change. Rural health clinics, we have the chance now to make significant changes to the healthcare landscape of regulation and certification and employment and reimbursement for rural health clinics in America. But it's time now to address the issues so that the window of opportunity that we have does not fade from view, and we don't lose more rural health clinics and see their doors closed, but rather new ones open and continue to serve the underserved communities and the rural communities that are all over and dotted all over our United States landscape. I wanted to, usually there are multitudes of websites and URL addresses that I put at the end of the presentation, but I just thought that it would be nice for you to see the organizations and certainly some of the websites where you can access wonderful information, thorough, current, and explanatory, so that whatever your needs are or whatever you want clarification on or want to learn, you certainly can find, not only through many of the national organizations and the national websites, but your state Office of Rural Health, and CMS is the one who governs it, so you can always go to cms.gov to the Medicare Learning Network, and that provides a lot of information as well on rural health and how it's changing. I want to thank you. I hope the information has been a little bit helpful, and I certainly hope that in the future, I wish you health, wellness, and a solid foundation and a wonderful landscape for your rural health clinic and the patients that you serve. Thank you, Texas.